Today, we are diving into a huge and honestly a really frustrating puzzle in healthcare. It's this: why do we pour so much money into fixing the system, especially for the sickest among us, and yet see so little change? We're going to unpack how a really promising idea ended up becoming a total paradox.
Okay, let's just start with the question that I think is on everybody's mind. You see the massive bills, right? You hear the stories about waste and inefficiency, and you can't help but wonder, where is all that money actually going? Why aren't we seeing these amazing, life-changing outcomes for everyone? Well, it turns out the answer might be hiding in plain sight, inside a single, very powerful, and very misunderstood word.
And that word is value. You see, the problem is we can't even agree on what value in healthcare is supposed to mean. On one side, you have the business frame. It's all about metrics, ROI, profit, efficiency, basically keeping costs down. But on the other side, you have this humanistic frame, which says, no, wait a minute. Value is about equity. It's about a person's well-being, their ability to bounce back from hardship.
And this isn't just some academic debate, you know? This conflict, this tale of two competing goals, it literally shapes every single decision that gets made in our healthcare system.
Now here's where it gets really tricky. Because nobody agrees on what it means, the term value-based healthcare has become this empty buzzword. And that allows anyone, really, to twist it to fit their own agenda. It creates this fog of confusion, where it's way too easy for financial goals to completely overshadow what patients actually need.
To see this in action, just look at these two major thinkers. On one side, you've got Michael Porter, the business guru. He gives us this very tidy formula. Value is just outcomes divided by cost. Simple, right? It's clean, it's measurable, it's very business. But then, on the other side, you have Dr. Don Berwick, and he says, hold on, value is not a math problem. It's about the entire system's purpose, to preserve, restore, and improve health in every way. And that requires a much, much bigger lens.
To really get what Berwick is talking about, we have to completely change how we look at the problem. We need to start thinking in systems.
So in system science, healthcare is what you'd call a complex adaptive system. What that means is you can't just tinker with one part and expect a neat, predictable outcome. Everything is connected. The behavior of one part completely depends on the behavior of all the other parts. So you push a lever over here, and something totally unexpected and wild might happen way over there.
A really great way to picture this is to think of a vortex. A vortex works because it has a super clear purpose, that focal point in the middle that everything spins around. All its interconnected parts create this flexible but strong structure. And there's this constant flow of information that lets it adapt and restabilize when it gets hit. But here's the key. If that purpose gets fuzzy, the whole thing just falls apart.
Okay, so this all sounds a bit abstract, I know. But how does it actually apply in the real world? Well, let's look at a huge test case where the system's purpose was put on trial. The whole effort to help patients we started calling super-utilizers.
So for years, the data was screaming at us. A tiny, tiny percentage of patients were responsible for a massive chunk of all healthcare costs. We're talking people with incredibly complex chronic conditions, often facing huge social barriers. And so naturally, they became this intense focus for anyone trying to control spending. The logic seemed almost foolproof. If you can just help the small group, you'll solve a giant piece of the cost puzzle.
And this gave rise to this big idea called hotspotting. A famous article in 2011 made it super popular, and then financial incentives from the government basically supercharged the whole movement. The idea was simple and sounded great. Wrap these patients in intensive, coordinated care. It seemed logical, it seemed compassionate. Honestly, everyone was convinced it was going to be a game changer. But then, 2020. A huge, gold standard study came out with a bombshell result. The program had no significant impact on hospital readmissions at all.
So what on earth went wrong? I mean, how could something so logical just fail? Well, this number right here, it gives us a massive clue. Over 70% of the studies on these programs focused almost entirely on things like hospital visits and costs. The only way they were measuring success was financial. It was Michael Porter's formula, outcomes over cost, playing out in the real world.
And this quote just hits it home. Researcher Carmel Mary Martin puts it perfectly. When you get so hyper-focused on those narrow metrics, you don't just fail to help, you actually risk creating a system that punishes vulnerability. You're literally measuring the wrong thing, and it's causing real harm.
So when you connect all these dots, you realize the failure of hotspotting wasn't a failure of effort or good intentions. It was a fundamental failure of value.
And this is the absolute key takeaway. The problem was never the patient. The problem was a system that was perfectly designed to chase the wrong goal. It was built around a business definition of value, cost containment, when the very people it was supposed to be serving desperately needed a humanistic one.
So why did these interventions fail? A few big reasons. One, they completely ignored the messy, multi-level reality of people's lives, the social, the biological, the political factors. Two, they treated a complex, adaptive system like it was a simple machine. And three, at the end of the day, they prioritized the hospital spreadsheet over the person's actual well-being.
So if cost containment is the wrong destination, where should we be heading? Well, the research points toward a much more powerful and, frankly, more human goal: resilience. Let's just break down what that shift really looks like. So instead of being obsessed with reducing admission rates, we focus on improving a person's entire health journey. Instead of a top-down, centralized strategy, we build up local care and give communities more power. The goal stops being about just containing costs and starts being about building real, systemic resilience and equity.
So what is systemic resilience? It's the ability of a person and their entire community to weather a storm, to take a hit, like a health crisis, and bounce back, to restore stability. It's about building strength and capacity from the ground up, not just running around patching leaks from the top down. It's proactive and it's deeply human-centered.
And that leads us to this incredibly powerful idea from systems science. It goes like this: all organizational systems are perfectly designed to get the results they get. Think about that. The super-utilizer paradox wasn't a mistake or a bug. It was the exact result our system was designed to produce. So the real question, the one we all have to ask ourselves is, what results do we actually want our healthcare system to be designed for?